harmonic 3D and 4D. So let's begin with tissue harmonics. Have you ever wondered why different musical instruments sound different, or perhaps different people's voices sound different? Well, there are principally two reasons for that. Different musical instruments have a varying bandwidth, the spectrum of frequencies they're capable of emitting. But also they are different in the harmonic content. And harmonics add sound quality to musical instruments, to people's voices, and harmonics is something we encounter in clinical imaging as well. Now, before we can talk about harmonics, we need to explain the concept of nonlinear propagation. Now, we know that on average, the propagation speed of sound is constant throughout soft tissues at about 1540 meters per second, plus or minus about 5% variation. Now, we do know that the speed of sound varies within the actual compression and rarefaction part of each cycle. Remember that the medium undergoes cyclical changes in particle density and stiffness with the propagating wave. So in fact, sound doesn't propagate continuously through tissue at a constant velocity. Rather, it speeds up and slows down during each compression and rarefaction cycle. When particles of the medium are in a compression stage, they are stiffer, and therefore sound travels slightly faster. When particles are in a rarefaction part of the cycle, the stiffness is less and the speed of sound slows down. So we have cyclical changes in the propagating velocity, and on average it is a constant at about 1540. But it is these cyclical changes that introduce distortions into the propagating wave, so that the initial sound wave might be nice and sinusoidal, but as the sound propagates in the tissue, this nonlinear propagation starts to introduce distortions. These distortions are higher order frequencies, and they are called harmonics. So when we talk about harmonics, the first harmonic is really the fundamental frequency. So for instance, when you're using a 3 megahertz transducer, 3 megahertz is the first harmonic. The second harmonic is twice the fundamental, so it'll be 6 megahertz. Third harmonic, 3 times the fundamental. So in the case of a 6 megahertz transducer, it would be 18 megahertz, for example. Now, when we do tissue harmonic imaging, the ultrasound system has to extract that harmonic signal from the returning echoes. This is a very difficult task. And the primary method for doing this is phase inversion. How does this work? Well, picture an ultrasound transducer that transmits a ultrasound pulse into the patient, and this pulse has a particular polarity. For example, it begins with compression and then there's rarefaction. This pulse will propagate into the tissues, echoes will return back to the transducer, and then will be held in the receiver. And next pulse is sent along the same scan line, but this pulse will be opposite in polarity. Where there was compression, there is now rarefaction. So the two pulses along the same line are out of phase, they are opposites. Echoes from this pulse will return back to the transducer, and the two echo signals will be mixed in the receiver. Because the initial pulses are of opposing polarity, whatever is fundamental frequency will undergo destructive interference, and the signal will be cancelled out, and whatever is left behind is harmonics. So you can see that the extraction of harmonic frequencies is done on the basis of destructive interference. That's how phase inversion imaging works. But the sacrifice we have to make is that each scan line has to be sampled twice by signals of opposing polarity, and this takes a little bit of time. So therefore our temporal resolution and frame rate is less in tissue harmonic imaging. It's possible to extract pulses in other ways, for example, to do this with pulse encoding and then mathematical algorithms that can look for the harmonic content, but that is too difficult, and so the primary method is phase inversion. Now here I would like to just clarify that in this segment we're talking about tissue harmonic imaging, not contrast harmonic imaging. So here we'll discuss how echoes are generated and processed from native tissue at normal power output settings. And we'll talk about contrast imaging in a different section. So let's take a clinical example of a sonography using a curvilinear transducer such as the one shown. This you can see is a broadband transducer operating at frequencies of 1 to 5 megahertz. It is a multi-frequency selectable transducer. Almost all ultrasound machines now allow you to do that, to actually choose the bandwidth within which the transducer will operate, either towards the higher frequencies, offering better spatial resolution, or operating towards the lower frequencies, in which case it can offer better penetration. Almost all ultrasound transducers nowadays are tissue harmonic capable. So for instance, with this transducer that can operate between 1 and 5 megahertz, you can transmit a 2 megahertz incident pulse and receive the second harmonic at 4 megahertz. And that would work because the 4 megahertz is still within the operating bandwidth of that transducer. Or you could transmit at 2.5 megahertz and receive the second harmonic at 5 megahertz. That would still work as well. But we cannot transmit at 3 megahertz because the second harmonic would be 6 megahertz, and that is beyond the operating range of the transducer itself. Remember, the transducer contains piezoelectric material that physically deforms in response to receiving echoes. And so if we have a transducer that is designed to transmit and receive at 1 to 5 megahertz, it cannot simply work at higher frequencies. So there's that limitation. So you can see that in order for harmonics to be able to be received and analyzed, we generally need to use broadband transducers, and those are the transducers available on all medium and high level systems. Because the tissue harmonic imaging usually requires a lower transmit frequency in order to allow us to receive the higher order harmonics, it means that there is some reduction of axial resolution. For instance, in using the transducer that I've first shown you in the slide, you may be able to do an abdominal ultrasound at 4 megahertz without harmonics. So 4 megahertz on transmit, 4 megahertz on receive. But you could not do tissue harmonic imaging with the second harmonic at 8, so 4 megahertz transmit and 8 megahertz receive. Those transducers doesn't have a wide enough bandwidth. Also, there will be some limitations in terms of the depth of penetration. We would not expect the 8 megahertz echoes to return, for example, from a medium to larger size patients. So with tissue harmonic imaging, in general, the transducer must transmit at a slightly lower frequency, which then limits the axial resolution capability. Now, another thing that is quite interesting about harmonics is how the intensity changes with depth. So in this diagram, we're going on the x-axis is the depth, starting with the body wall and then going through deeper tissues and going quite a distance into the patient. You can see that the fundamental frequency in blue drops off quite dramatically, and this is due to attenuation. You'll be now familiar with the attenuation coefficient, which varies from maybe 0.1 to up to 1. It's decibel per centimeter per megahertz. Now, while we have a relatively even drop-off of the fundamental frequencies, if you have a look at what happens to harmonics, it's quite a different story. Harmonics actually start very, very low, close to the transducer, and they require distance to build up. So harmonics increase in intensity as sound propagates through the patient, then peak, and then reduce with depth. And this is a very important feature of harmonics, because you can see that very few harmonic frequencies exist where we have a particular problem, and that is the patient's body wall. Because there are few harmonics, and there are very few artifacts associated with it, with body wall as well. So that's one of the ways that harmonic imaging reduces artifacts such as reverberation, is by literally bypassing the body wall. There's simply not enough harmonics generated that close to the transducer. Another interesting observation about harmonic imaging is that the harmonic signal is really intense in the center of the beam, but peters out to the edges of the beam quite rapidly. In fact, the generation of harmonics is proportional to the square of the fundamental signal. This means that there's a lot of harmonics in the center of the beam, but very, very few harmonics on the edges of the beam. And the fortunate consequence of this is that the beam appears smaller in tissue harmonic imaging. This is how tissue harmonic imaging contributes to reduction of beam width and slice thickness. So I've now described how tissue harmonic imaging can improve our resolution, not in the axial dimension, but at least in beam width. Now, we have also touched on the fact that harmonics require time to generate. Time means distance, and therefore very few harmonics are present on the body wall. So harmonics sometimes are said to bypass the body wall, and as a consequence, we have reduction in the body wall artifacts. Here are some clinical examples of a gallbladder containing some sludge. In the fundamental imaging, the sludge is not at all apparent, but with tissue harmonic imaging, it is. This is a good example showing how tissue harmonic imaging improves contrast resolution of your clinical ultrasound images. So let's consider some of the advantages and disadvantages of tissue harmonic imaging. As we have described, because harmonic imaging bypasses the body wall and reduces beam width, it therefore improves contrast resolution. It dramatically improves the resolution of cystic structures because there are no internal structures within cysts to generate echoes, and tissue harmonic imaging is less prone to acoustic noise and clutter. We have reduction of many artifacts, including reverberation, including side lobes, including acoustic noise. These are the predominant artifacts that contaminate cystic structures when we do transabdominal imaging. And because of the smaller beam width, we have better lateral as well as elevational resolution. And by elevational resolution, I mean slice thickness. Now let's have a look at the disadvantages. So some of the disadvantages are that tissue harmonic imaging is associated with slightly poorer axial resolution. This is due to the fact that the transmitting frequency has to be low. If the transmit frequency is low, this lengthens the spatial pulse length. And by now you should be familiar with the formula for axial resolution, which is half of spatial pulse length. So whenever you have a longer spatial pulse length, then you have a larger value of the axial resolution, and that is not desirable. Another disadvantage is poorer temporal resolution. Remember that the extraction of harmonic frequencies is usually achieved using pulse inversion, and therefore each line of sight needs to be sampled twice in order to get the harmonic echoes out of the returning signal, and therefore your temporal resolution will suffer a little bit as well. This can be compensated by, for example, reducing your line density, but reduction of line density is then associated with lower lateral resolution. So as with many aspects of ultrasound, there are always trade-offs here. Tissue harmonic imaging is sometimes associated with lower penetration as well, and this is due to the fact that the returning echoes are now much higher frequency and they may attenuate on the return trip. And in some patients, tissue harmonic imaging actually produces worse images. And there's a specific body type of patients, sometimes referred to as glass body patients. These are patients who transmit sound beautifully and where there's very little imaging artifact present anyway. In those patients, you can scan them on fundamental imaging and still get a very good contrast resolution, and then you'll have the additional benefit of better axial resolution. So on a rare occasion in a glass body patient, you have better result using normal conventional ultrasound. Now finally, I just wanted to return back to kind of discussing what an ultrasound beam is, because we often think about the beam as the field of energy that goes out into the patient. However, that's not how engineers think of an ultrasound beam. They think of an ultrasound beam as not only the transmit but also the receive and any additional processing made on the returning echoes to try to reduce beam dimensions. So let me just consider two echoes, which are denoted here as little circles. One of the first things that happens when we transmit an ultrasound beam is that the transducer will recognize where the focal length is. This is a user selectable region, and will then select the correct number of elements within the aperture, and so the aperture size itself contributes to beam focusing. Then we have transmit focusing, which then uses phase array technology. All of the elements within the transducer are connected to electrical connectors, and you might have a curvature of transmitting and the electronic pulses within the aperture to further assist focusing. So that's transmit focusing using phase array technology, and I'm sure our previous speakers would have covered this beautifully in the preceding presentations. Now we can also do receive focusing. So receive focusing is a sort of reverse of transmit focusing, whereby the machine knows the curvature of the returning echo from a particular target at a particular depth, and will selectively look for echoes that have that curvature. That is called receive focusing. Echoes that do not have the desired curvature, for example, echoes from the edges of the beam, will be ignored. So all of these technologies are contributing to the reduction in the perceived beam width. We also have dynamic receive aperture. I'm not going to discuss it here because it is quite a complex topic, and it could have been covered before. And then if on top of all that we add tissue harmonic imaging, remember that harmonic echoes are generally mostly generated from the middle of the beam, where the intensity is the strongest. So the beam is physically narrower using tissue harmonic imaging. And so these are all the technologies that contribute to reduction of beam dimensions and contribute to lateral resolution. And in the case of two reflectors in the far field here, they would not be resolved by simply aperture contribution alone, or transmit focusing alone, or receive focusing, or dynamic receive aperture, which doesn't really contribute to reduction of beam width deep in the image. But with tissue harmonic imaging, we would be able to discriminate these. So tissue harmonic imaging improves your lateral resolution. The final question is, when should we use it? Well, on most systems, tissue harmonic imaging offers better imaging performance over conventional ultrasound most of the time. So you'll find that it is a default part of most of the presets that you'll be working with. And that is the end of this subsection. So let's move to our next section. In this section, we're going to talk about spatial image compounding. So spatial image compounding is technology that really counteracts the negative aspects of Speckle. So what is acoustic speckle? Well, acoustic speckle is the random variation of pixel brightness within tissues. Acoustic speckle is really what gives organs their tissue texture. However, acoustic speckle does not actually represent real structures. Rather, it represents an interference pattern that's formed when small echoes, which would normally not be detected, interfere with each other to create echoes of high enough intensity, but these are not echoes that actually represent any tissue reflectors. My colleague Robert Gill explained this in his textbook very nicely, and I'll borrow one of the images here. So consider the image on the right bottom part of the screen. In this case, we have got some very small tissue reflectors, and the tissue reflectors here produce very small ultrasound echoes. These echoes are too weak to be individually detected by the ultrasound machine. But you can see that as the small wavelets of ultrasound propagate, these wavelets will start to merge, and they will constructively and destructively interfere with one another. In this example that I'm highlighting, there is a region of constructive interference between three very small wavelets, and at that point in space, the echo will be quite strong, and it's possible that this echo will then return back to the transducer and form one bright dot on our ultrasound display. You can see, however, that this area of constructive interference, where this white dot may be located, does not represent any soft tissue reflector at that location. Instead, it is an echo that has arisen from the constructive interference of very small wavelets of ultrasound. So next time you look at tissue texture, for example, of a liver or kidney, remember the texture itself and the distribution of brighter and darker pixels does not necessarily represent real structures. Certainly, very large structures such as vessels or masses or organ boundaries are depicted for us accurately on the ultrasound, but the tissue texture is largely due to acoustic speckle. You can see acoustic speckle in solid organs. Here's an example of the liver, and I will just remind you that where you see a bright reflector does not necessarily represent a real structure. Now, one of the earliest forms of image compounding, whose purpose was to soften images and make them smoother and make them less prone to speckle, was persistence, also known as frame averaging. With persistence, it's a very simple form of compounding. One frame of ultrasound image is simply layered onto another, and then successive frames are stacked together and merged into a transparency. Eventually, you'll reach a stack where a new frame is added and the old frame is taken away. This does work a little bit, particularly when you're sweeping through tissue, but it doesn't really work very well statically. And that's because with persistence, the same tissue is always interrogated at the same angle. And acoustic speckle is angle dependent. So if we're looking at the same pattern of speckle from the same angle, it's always going to look the same. What we need is to look at the same region of tissue from different angles. From different angles, speckle will appear different, and when we put those frames together, speckle will be averaged out, and it will be easier to see, for example, focal lesions within tissue. The technology that achieves that is spatial image compounding using phase array technology. You can see in the diagram on the right that an image with where spatial compounding is used is formed out of a lattice work of beams, some coursing straight into the patient, which would be conventional ultrasound, but some also at varying transmit angles. The varying transmit angles are achieved using phase array technology, where the timing of the excitation of different elements within the aperture allows for beam steering. Some of the advantages of spatial image compounding is that you get much better border definition. Where in the past, for example, you're looking at a simple cyst using conventional ultrasound with all the beams orientated straight into the patient, a cystic structure will generally generate echoes along the top and bottom, but it will fail to fill on the sides. With spatial image compounding, some of the beams will be interrogating that part of the cyst at favorable angles, and so the cyst boundary will fill, and instead of seeing cysts as just a shell on top and shell on the bottom, we now have full definition of cysts, various masses, and organ boundaries. Because of this, we also have improved lesion conspicuity. By conspicuity, I mean visibility. We have better contrast resolution, and many artifacts are averaged out because artifacts are also angle dependent. So, for example, reverberation is much reduced with spatial compound imaging. Now, as any user selectable control, there are some advantages and there are some disadvantages. So one of the disadvantages is that some of the desired artifacts can be reduced or eliminated. For example, enhancement and shadowing. This is very important to recognize. If you are using shadowing, for instance, as a diagnostic criterion, and this might be in looking for renal calculi or looking for something sinister, such as a breast malignancy with microcalcifications, you need to be mindful that spatial image compounding will tend to remove these artifacts from the image. So sometimes the spatial compounding needs to be turned off. Another disadvantage is that the temporal resolution is reduced. You can see in the diagram of spatial compounding that this is a very processor-heavy task. You are composing frames from conventional images as well as images that are steered at varying angles. In the example that you're seeing, there's only 3 lines of compounding, but many systems are capable of much, much more. For example, 5, 7, or even 13 lines of compounding. So all of this takes time, and your temporal resolution will be reduced. Sometimes images can also appear a bit fuzzy, particularly at the depth, and there may be a loss of lateral resolution. And this happens because there's a small amount of refraction happening during beam transmission. So the echoes may be misaligned, particularly at depth and particularly beyond your focal point. On many ultrasound machines, you can do a lovely experiment to see how image compounding works by placing a metal pin, for example, a paper clip, on the transducer surface, and that paper clip will cause a ring down artifact on the image that you can see. In the first image on top left, the pin is resting on the transducer, it's reverberating, and that reverberation artifact propagates straight down. This image is conventional and there's no compounding involved. The minute you turn spatial compounding on, you then start to see reverberation artifact in multiple directions, representing the beam steering of that particular aperture within which that metal pin is resonating. On the system that I've used here, which is a Siemens system, you can turn the compounding up to quite a high level. So on the bottom left, we have 1, 2, 3, 4, 5 lines of compounding. And then the bottom right has 9 lines per aperture. Very often with a high level of compounding, there are very few gains to be made, and the temporal resolution drops down considerably. So often modest amount of compounding is perfectly sufficient. In terms of clinical images, spatial compounding reduces the appearance of speckle. You can see that in this example of a hip ultrasound, where the uncompounded images are very speckly, and with compounding, there's a lot more smoother and well-defined texture. We also have better border definition, and you can see that here, for example, in terms of tissue boundaries, are much better defined with spatial compounding. If we are looking for any sort of focal liver lesion, focal liver lesions are also much better visualized, and that would be the same for lesions in other organs, for example, kidney, and as well as normal anatomy, for example, during obstetric ultrasound. In musculoskeletal imaging, spatial compounding also reduces your anisotropy effect. And this is because some part of the beam is always interrogating a curved structure at a favorable angle. So, for example, in these images, you can see some muscle fibers on the conventional imaging, but not so many. There's much better definition of the muscle fibers on spatial compounded images, because some of the beams are always interrogating those at a favorable angle. There are many other advantages, and I'll pick this clinical image to just demonstrate that this is a picture of a neonatal spine. I've been doing ultrasound for many years, and some of the earlier systems did not have spatial image compounding. So in the past, doing a spine ultrasound, for example, on a neonate was very difficult, because you've got bony elements that cast acoustic shadows, and we had very large shadows coming across the image. So you could only see the spine through narrow gaps in the image. It was very, very technically difficult. However, nowadays where there will be an acoustic shadow, and you can still see that there are some vague acoustic shadows there, we can also have a window that allows transmission of compounded beams underneath the vertebral body, and therefore nicely outlining the anatomy there. So the anatomy nowadays is it's possible to interrogate it even in the presence of shadowing. So this is a tremendous advantage, particularly in applications where shadowing can occur and it cannot be circumvented. However, it's also important to recognize that shadowing sometimes is your friend, and it's a diagnostic criterion for example, calculi, microcalcifications, and so on. So in these images of a very small renal calculus that is being interrogated using a linear array transducer, this must be either small adult or a child, you can see that in a compounded image that the shadow is not very evident, particularly lower down, whereas with spatial compounding turned off, the acoustic shadowing is very, very well appreciated. And in some applications, seeing shadowing is very, very important, and this is particularly in breast work, because microcalcifications and small tumors are just very difficult to visually see on the background of the heavy texture that breast tissue has anyway. So sometimes it's actually easier to look for shadows, because shadows are larger vertical stripes in the image, and it's visually easier to identify shadowing than it is to identify microcalcification. So in those applications where you need to be able to see these artifacts, it's important to perform a survey with spatial compounding off as well. Now, finally, I wanted to talk about temporal resolution. Here are two video clips of just scanning through some muscles in the thigh. The left video clip has very good frame rate, it's very sharp, and movement is well represented. The right video clip is very soft, there's a lot of motion artifact in there, and that is the video clip that is obtained with spatial compounding on. So while temporal resolution is it's an important thing during surveying, you need to keep in mind that if you're making large movements or fast movements, your ability to see structures will be reduced with spatial compounding on. There's a kind of a visual persistence effect in there. There are ways to counteract that. For example, you might be able to reduce the level of compounding. If you're looking at shallower structures, then PRF is higher and frame rates are generally higher. So this is particularly important when you're looking, for example, at large organs, and you're surveying large organs like a liver, for example. If you have a high level of compounding and the organ is larger, your depth setting is deeper, then spatial compounding can sometimes produce fuzzy images during survey. A lot of it does depend on the quality of the ultrasound system, how deep you're looking, and exactly what the system settings are. It's important to be aware of that. So finally, when should spatial compounding be used? Well, spatial compound imaging offers better imaging performance over conventional ultrasound most of the time. So much like tissue harmonic imaging, you'll find that it is a component of most of your standard presets. And we'll move on to the section on 3D and 4D imaging straight away. First, let's clarify some terminology. So the term 3D simply refers to three-dimensional static reconstruction of images from ultrasound volumes. 4D means that the three-dimensional acquisition and display is in real time. And there's also other displays, for example, STIC, which stands for Spatial Temporal Image Correlation. And STIC is an interesting feature. It's used in echocardiography, for example, and fetal echocardiography as well. STIC allows the acquisition of multiple random 3D slices, which are then stacked in the correct order in order to reconstruct a 4D video clip. So whilst stick is not a real-time method, it allows interrogation of very fast-moving structures that otherwise would be very difficult to do with 4D. So what are some of the volume acquisition methods that we can use with ultrasound? Well, I think the most traditional one would be having a conventional ultrasound with a transducer having position sensors, so that the ultrasound system knows where the transducer is in space, and then when you move the transducer, you can acquire successive slices, and those slices can be correlated to three-dimensional space. Nowadays, position sensors are used in fusion imaging, where you need to correlate CT, MRI with ultrasound images, for example, in an interventional setting. But apart from that, position sensors are not commonly used nowadays. Perhaps the most available method of 3D acquisition is freehand method, where the operator or sonographer radiologist simply sweeps the transducer along a segment of tissue whilst the machine is acquiring individual slices, and those slices can then be reconstructed into 3D volume and reprocessed. That is available on all high-end ultrasound systems, and it's a feature that's quite nice, and I find it sometimes underutilized. We also have automated acquisition methods. This could be with a mechanical transducer, such as the transducer pictured here. This transducer has a conventional array, but it's mounted on a swinging armature onto an electric motor. That motor moves the array through the field of view in a wobbling fan-shaped fashion. You can define how wide the angle needs to be, and so the 3D volume is then acquired mechanically this way. There are also matrix array transducers. Matrix array transducers are two-dimensional arrays because there are elements in two planes. That allows for beam steering in 3 dimensions. So a matrix array transducer can acquire a conical field of view of data electronically without the need for moving parts. Therefore, these transducers are very stable, very robust, and acquisition is also quite fast. These matrix array transducers are used in echocardiography, abdominal imaging, as well as in obstetrics and gynecology. I think these are very, very nice transducers. Now, how do we even navigate around a 3D volume display? It's really not that difficult. So here is an example of a neonatal brain ultrasound with 3D. So this is common to most ultrasound systems. The top left image is the scan plane image. That is the plane in which we have acquired the 3D volume. The next image is transverse to that scan plane. So for example, if we have acquired the volume in transverse section, then the transverse to scan plane will be sagittal section. Or if we have acquired the volume in sagittal section, then the transverse to the scan plane will be transverse section. The next image down is a coronal plane rendering, and this is sometimes abbreviated to C-plane. And then we have a volume rendered image, and this volume rendered image is obtained, in this case, from a bird's eye view onto the dotted line that you can see in the other scan planes. So right now, because the dotted line is resting outside the ventricular system, we are mostly seeing sulcation and gyration of the brain. However, if we lower the line into the ventricular system, then we would see the dilated ventricles in this case. And so this is generally how you orientate on 3D images, and the conventions are very similar between different manufacturers. It might be desirable to organize the display differently. So for example, you may be able to select a larger field of view for one image and have the other images smaller as thumbnails on the side, but in principle it is exactly the same. Now, one of the important teaching points here is that the C-plane and volume rendering are the most useful aspects of 3D imaging, because these projections cannot be obtained manually. Sagittal and transverse projections are easy to do manually, so there's very little value in employing 3D imaging to do that. But the C-plane is not obtainable, and of course volume renderings are also not obtainable. Now in this case, we have used a freehand sweep of patient's anatomy. This is an example of a varicose vein, and reconstructed that vein on 3D ultrasound here. This is done freehand, and you can still obtain very, very good image quality. The usefulness of this image is that here we are perhaps performing a venous intervention using a transcatheter technique like a laser or radio frequency ablation, and the vascular surgeon needs to know, will he or she be able to pass a guide wire and catheter through the venous system? That's very, very difficult to determine from the video clip. I mean, it's just cognitively too much going on with too many branches, and it is very, very hard. But on the 3D reconstruction, which is a bird's eye view of the vein, this is much, much easier, and you can see this will be quite a challenge to perform a transcatheter technique due to the curvature of the vessel. So sometimes 3D ultrasound can be very useful for decision making. I think most people are familiar with 3D ultrasound in obstetrics and gynecology. So here we have an example of a C-plane rendering of a bicornuate uterus, for example. And this is a tremendously helpful sort of thing, because without 3D rendering, you would not be able to obtain this view of the uterus. In fact, some systems nowadays offer not just plain sectional imaging, but also curved volume. So for instance, if this bicornuate uterus is also antiverted, for example, having this sort of contour with a curved endometrium, nowadays you can define a curved plane of section for your 3D imaging, so that you're literally slicing along the endometrium, which is where the diagnostic information is. The right bottom image shows a 3D multiplanar reformat of an ovary. You can see the ovary in all three dimensions. You might wonder why this would ever be useful, because the ovary is readily obtainable using manual methods. But there may be some uses for it. For example, it's easier to count follicles in patients undergoing infertility workup. There are, in fact, automatic systems that can do that for you. Or maybe you have a patient in considerable pelvic pain, where time is of the essence, and so you might be able to obtain 3D volumes of uterus, ovaries, and so on, and then reconstruct and measure all of the things offline with the transducer out of the patient. Here are some images of 3D of a stereoptic liver.